Hello everyone. Welcome back to the series of lectures in neurology. Today we'll be discussing a very important topic, which is Guillain-Barré Syndrome. Okay, so till now we have discussed about the upper motor neuron and we have discussed about the spinal cord. So from now we'll be discussing about the low motor neuron, which includes your radicals, the nerves, the neuromuscular junction and the muscle, right? So we will start off our discussion with GB syndrome. So what exactly is this GB syndrome or your Guillain-Barré syndrome? So this is basically an acute onset fulminant polyradiculoneuropathy, right? So every word in this sentence is very, very important, right? So what does this mean? The onset is acute. The onset of what? The onset of weakness is acute. It is explosive in onset. So there is an acute onset weakness, right? Acute onset weakness of what type? Of what type? Just now I told you it is of the element type of weakness, right? So there is an acute onset element type of weakness. Element type of weakness means, will there be spasticity or flaccidity? There will be a flaccid paralysis. There will be a flaccid paralysis. Okay? So there is an acute onset fulminant element type of flaccid paralysis. Alright, that is clear. Now what is the meaning of polyradiculoneuropathy? Polyradiculoneuropathy means both the radicals as well as the nerves are affected. Okay, so polyradiculoneuropathy means both the radicals and the nerves. Radicals are what? Radicals are the nerve roots which arise from the spinal cord, right? So from the level of the nerve root, which is your radicals, till it goes and supplies the muscle is your element, right? So we have learned that in the basics of neurology. So there is radicular involvement and there is neuropathy as well. So the nerves as well as the radicals are affected, and hence there is both proximal plus distal involvement. There is both proximal plus distal involvement. Okay? And this entire process is usually beginning in the lower limbs and then it progresses upward. So this is a characteristic of feature which is called as ascending paralysis. Okay, so you have ascending paralysis because it begins in your limbs and then goes upwards. And most often it is a symmetric ascending paralysis. Okay, it is a symmetric ascending paralysis, right? It's not that one limb is affected, then your next limb is affected, then your next limb is affected. That is more common in your spinal cord disorders. So asymmetric involvement is more common in spinal cord disorders, especially your compressive myelopathies. But here you have a symmetric ascending paralysis. Okay, so this has to be very, very clear, because any patient who presents with element type of weakness, you will have to localize it to the radical, to the nerves. Is it the NMJ problem or is it a muscle problem, right? So this is an acute onset fulminant polyradiculoneuropathy where both the radicals as well as the nerves are involved. There is ascending paralysis and it is a flaccid paralysis. Okay, it is a flaccid paralysis. Okay, so very clear about what exactly is GB syndrome. Fine? Okay. Now, GB syndrome predominantly affects both males and females. It can be found in the children as well, but it's more common in males. Okay, GB syndrome has antecedent events in 70% of the cases. Okay, so there are antecedent events which can trigger your GB syndrome. GB syndrome, similar to many other disorders like your myasthenia gravis or multiple sclerosis, is also an autoimmune disorder. Okay, and hence it also has a trigger. So antecedent events are acting as triggers for GB syndrome. So 70% of the cases of GBS have some form of an acute infection, predominantly a respiratory or a gastrointestinal infection. So history of upper respiratory tract infections, cold, cough, fever in the past 1 to 3 weeks, or history of diarrhea in the past 1 to 3 weeks, followed by a flaccid paralysis, you should think of GB syndrome. So 70% of the individuals have up to some kind of a antecedent event up to 1 to 3 weeks prior to your paralysis. Okay, fine. So what are the organisms which have been implicated in this GB syndrome? It includes Campylobacter jejuni, Then it can be due to CMV, human herpes virus, mycoplasma, right? So what are the organisms which are implicated in this GB syndrome? It includes Campylobacter jejuni, CMV, human herpes virus, mycoplasma. Okay. Apart from this, there can be non-infectious triggers for GB syndrome as well. So what are the non-infectious triggers? Other autoimmune disorders like SLE, Hodgkin's lymphoma, antecedent surgery. Many a times surgery can predispose to GBS. Then transplant, especially a bone marrow transplant. Especially a bone marrow transplant. Okay. So this is about the antecedent events which can cause or precipitate your GB syndrome. So what have we learned? GB syndrome is an acute fulminant polyradiculoneuropathy which is predominantly characterized by element type of weakness. So there is flaccid paralysis, right? It is a symmetric type of weakness and it is ascending in nature. It begins with the lower limbs and progresses upward. And because there is polyradiculoneuropathy, you have both proximal as well as distal weakness. Okay, fine, right. Now let us understand the immunopathogenesis of GB syndrome. So why exactly is this happening, right? So we have learned that the antecedent events can be a trigger factor for GB syndrome. Now apart from this, there is this concept of molecular mimicry. Where else had we learnt about this molecular mimicry? We have learnt it in rheumatic heart disease, right? So there are antibodies which are produced by our immune system to fight whatever was the trigger, maybe an infection was the trigger. But these antibodies are misdirected against gangliocytes which are present on the Schwann cells. Okay, so these antibodies are misdirected. They are misdirected against the gangliocytes which are present on the Schwann cells, mainly because these gangliocytes are also similar to the pathogenic proteins to which your immune system was acting. Okay, so these are present on the cell membrane of Schwann cells which are predominantly present in which nervous system? In the peripheral nervous system. Okay, so these gangliocytes are present on the Schwann cells only in the peripheral nervous system and not in the central nervous system. Okay, that's why GB syndrome is a disorder of the peripheral nervous system, not the central nervous system. Alright, so this affects the Schwann cells which are present in the axons or in the nodes of Ranvier, predominantly in the peripheral nervous system. So basically there are autoantibodies. Against your Schwann cells. Okay, so if there are autoantibodies against your Schwann cells, what does it finally lead to? This finally leads to destruction of the Schwann cells, destruction of the myelin sheath, resulting in what we call as demyelination. There is demyelination. So you may be wondering, demyelination is happening similarly in MS as well, right? So what is the difference between your multiple sclerosis and your GB syndrome? Why is it not the same entity? So here the antibodies are directed only against the Schwann cells in the peripheral nervous system. In MS, the autoimmunity is against the oligodendrocytes and hence MS predominantly affects the central nervous system. That's why the manifestations in GB syndrome is different from manifestations in multiple sclerosis. Okay, clear? Fine. The second type of immunopathogenesis is that this entire process can also trigger activation of dendritic cells which stimulate B cells, and there can be complement activation which is further going to enhance your myelin destruction. Okay, so this is further going to enhance your myelin destruction. So on the whole, we have learnt it in our MS as well. So we have your myelin sheath which is present here, right, on your neurons. So if there is destruction of myelin sheath, we used to have a saltatory conduction. The conduction is usually a saltatory conduction where the electrical impulses jump from one node of Ranvier to the other. Now if there is a demyelination, then the velocity of the impulse is going to decrease and there is going to be a block here, right? So the velocity of the impulse is going to decrease and there is going to be a block. So the velocity of the impulse is going to decrease and there is going to be a block. So this is what we call as conduction block, right? So conduction block is a characteristic feature which you see in demyelinating disorders. So the impulses are not going to get conducted any further. Okay, fine. So this is about your immunopathogenesis of GB syndrome, right? So main trigger can be an infection, or it can be a surgery, it can be a bone marrow transplant, and this is going to cause autoimmunity against the Schwann cells in the peripheral nervous system, and hence the disorder is basically going to affect your myelin sheath of the peripheral nervous system. So there is demyelination. Clear? Now let us understand the various subtypes of GB syndrome. So GB syndrome is classified into various subtypes. So the first and the most common one is called as AIDP. Okay, it's called as AIDP, acute inflammatory demyelinating polyneuropathy. Okay, acute inflammatory demyelinating polyneuropathy. Okay, so this is the most common type of GB syndrome, and this is the prototype that we actually discuss, that is your ascending paralysis with ascending type of flaccid paralysis, which basically begins in your lower limbs and progresses upward. Then you have a facial variant of that, where you have facial diplegia and paresthesias, where you have bilateral facial nerve involvement. The second variant is your AMAN variant, which is your acute motor axonal neuropathy, right? Though we have understood that GB syndrome predominantly has demyelinating features as is immunopathogenesis, over the course of time, this demyelination can also cause destruction of the axons, and in certain cases, especially like for example in your AMAN variant and AMZAN variant, you do not have demyelination, you rather have direct damage to the axons, and you have axonal neuropathy. So this is your acute motor axonal neuropathy, where you predominantly have only motor symptoms, and this is characterized by IgG antibodies to GM1 and GD1A. What is this GM1 and GD1A? These are basically the types of gangliocytes which are present within your axons of the neurons. Okay, so antibodies to GM1 and GD1A is in your AMAN variant. Okay, fine. Then you have your acute motor sensory axonal neuropathy, which is called as your AMZAN variant. AMZAN. Okay, here also you have antibodies to GM1 and GD1A, right? Then you have acute motor conduction block neuropathy, where you have predominantly conduction blocks on your nerve testing. So that is also characterized by GM1 and GD1A antibodies. And you can have a pharyngeal cervical brachial weakness, which is a rare type of syndrome. You can have pharyngeal involvement with dysphagia, and you can have cervical involvement with predominantly neck drop, and brachial weakness, arm weakness is more prominent. So this is GT1A more than GQ1B. So antibodies to GT1A more than GQ1B. This is a rare variant. Okay, so what you mainly have to remember is AIDP, AMAN, AMZAN, and the last of the ones, a very peculiar type of syndrome, which is your Miller-Fisher variant. Okay, so this Miller-Fisher variant does not really have weakness. Okay, Miller-Fisher variant has ophthalmoplegia, ataxia, and areflexia. Okay, so weakness will not be a prominent feature in your Miller-Fisher syndrome. Rather, this Miller-Fisher syndrome is basically characterized by ophthalmoplegia. So predominantly cranial nerve involvements, ophthalmoplegia, ataxia, and areflexia. So this is what we call as the triad of Miller-Fisher variant, and here you have GQ1B antibodies. So remember, GM1, GD1 is your AMAN, AMZAN variant, and GT1 is your pharyngobrachial cervical weakness, and GQ1A antibodies in your Miller-Fisher variant. The last is a variant which predominantly involves your central nervous system, and they can present with an encephalitis-like features. This is called as your Bickerstaff brainstem encephalitis. Okay, so this is about the various variants which are found in your GB syndrome. I hope we are clear till here. Now let us go on and understand the various clinical features in your GB syndrome. Whenever we speak of GB syndrome here, we will be talking about the prototype, which is your acute inflammatory demyelinating polyradiculoneuropathy, AIDP. Okay, so most of it we have already discussed. This is a rapidly evolving areflexic, predominantly motor paralysis, right? So again, every word here is important. It is rapidly progressive. It has an acute onset, rapidly progressive. What type of paralysis? It is an ascending paralysis, right? So the pattern is ascending. It begins in the lower limb and goes upwards, right? So the patient may clearly tell you that it began in the lower limbs and it goes upwards. Then you have a flaccid paralysis. You have flaccid paralysis mainly because of radical and nerve involvement, because of an element type of weakness. Why do you have areflexia? In element type of weakness, the reflexes are usually lost. When we speak of reflexes, it's your deep tendon reflexes. It is usually lost and hence you have an areflexic, predominantly motor paralysis. Okay. So what happens is whenever we speak about neuropathy, the nerves that can be involved can either be a sensory nerve or a motor nerve. So in neuropathy, you can have both sensory symptoms as well as motor symptoms, sensory loss and motor loss. But here it is predominantly a motor paralysis. So very, very important. They have a motor paralysis. Okay. But because there is nerve involvement, they can have, because there is nerve involvement, they can have subjective sensory symptoms. Subjective sensory symptoms in the form of tingling, in the form of paresthesias, in the form of numbness. Prior to the onset of your actual paralysis, you can have subjective sensory symptoms, but when you objectively examine them, look for loss of sensation, look for pain and temperature loss, look for vibration proprioception loss, it may not be present. Okay. So they can have subjective sensory loss. Okay. But in up to 10 to 15% of the patients, you can have sensory loss as well. Okay. In your AIDP, depending upon the rate of progression, you can have a rapid progression or a moderate progression. Sometimes the progression may not involve the upper limb as well, and it may be limited only to the lower limb. But in rapidly progressive, if it is progressing very, very fast, so it will involve the upper limb, right? You can have weakness of the lower limb, you can have weakness of the upper limb, you can have weakness of the trunk. But what are the dangerous things that you have to look out? You can have weakness of the respiratory muscles. You can have weakness of the respiratory muscles and the diaphragm. You can have neck muscle weakness as well. Okay. Then there are some variants of GB syndrome which can predominantly involve the bulbar muscles. We can involve the bulbar weakness, or even your AIDP which progresses rapidly can go and involve your bulbar cranial nerves, or even in your Miller-Fisher variant you can have bulbar weakness, right? So bulbar weakness is characterized by what? Dysphagia, dysphonia. Okay, you can have dysphagia and dysphonia. A very, very important thing that we should watch out for in your GB syndrome is the presence of this autonomic dysfunction. Autonomic dysfunction is a very, very important characteristic of GB syndrome, where there can be severe autonomic dysfunction which can lead to even death. Okay, so how do you identify autonomic dysfunction in GB syndrome? It is characterized by resting tachycardia. You can have resting tachycardia. And then you can have swings in your blood pressure. So it can go from severe hypotension to severe hypertension, right? You can have episodes of sweating, right? You can have episodes of sweating, profuse sweating, or there can be loss of sweating. So this severe autonomic dysfunction can actually lead to a vascular collapse and the patient can have a mortality as well, right? A characteristic feature of GB syndrome as per your traditional teaching is that the bladder is often spared. You do not have a characteristic bladder involvement in GB. When it comes to the cranial nerve involvement, the most common cranial nerve is your 7th cranial nerve. So GB syndrome basically causes bilateral element type of 7th cranial nerve palsy. Okay, so it is responsible for bilateral facial weakness. So in unilateral facial weakness, you can easily find out because there will be deviation of the angle of mouth to the other side. There can be drooping of the eyelids, there can be loss of nasolabial fold, right? You will have Bell's phenomenon. So unilateral facial weakness you can easily find out. But how do you find out bilateral facial weakness? That is very, very difficult to find. So many a times it is easy to miss out bilateral facial weakness. Okay, so there will be loss of nasolabial fold on both sides, and there will be weakness in closing the eyes on both sides. Okay, right? So there is bilateral element type of facial weakness. All right. And what is the risk of this bilateral element type of facial weakness? Because they will not be able to close their eyes completely in the night because of the paralysis of both the facial muscles. They have a high chance of exposure keratitis. They have a high chance of exposure keratitis. So that is something that you will have to watch out for. Okay. What are the other causes? Other causes for bilateral 7th cranial nerve palsy? Right, you have to remember sarcoidosis. You have to remember sarcoidosis. You try and remember Lyme's disease, sarcoidosis, Lyme's disease, Ramsay-Hunt syndrome. Ramsay-Hunt syndrome. Okay, so all of these are the other causes for bilateral 7th cranial nerve paralysis. All right, clear? So this is about the various clinical features. Don't forget a symmetric, areflexic, ascending type of flaccid paralysis. Okay, symmetric areflexes, ascending type of flaccid paralysis with subjective sensory symptoms, predominantly motor involvement and bulbar weakness, autonomic dysfunction. Bladder is often spared and bilateral 7th cranial nerve palsy can be present. Other cranial nerves that can be involved, your 3, 4, 6 cranial nerves can be involved in your Miller-Fisher syndrome. Then there can be 9, 10, 11 cranial nerves or 9, 10 cranial nerves involvement in your brainstem involvement. Okay, fine. Now, how do you diagnose your Guillain-Barré syndrome? Okay, so how do you diagnose your GB syndrome? So what are the characteristic features, right? So first, in your CSF finding, there will be elevated CSF protein by the end of first week. There will be elevated CSF protein by the end of first week. And there is a characteristic feature that we call as albuminocytologic dissociation. That means what? The CSF total count is usually less than 50 cells. The CSF total count is usually less than 50 cells, but the proteins are elevated. The proteins are elevated. Now, why is that so? That is because these proteins are produced by the inflamed radicals. The inflamed radicals are the one which basically produce proteins, and hence you have proteins within the CSF, but it's not an infection within the CSF, so total counts are usually low. And this is what we call as the albuminocytological dissociation. Okay, so there is a dissociation between the number of cells and the protein count in the CSF, because whenever we do a CSF analysis, for example in your meningitis, you would expect cells and proteins to go up together, right, hand in hand, but this is a characteristic feature. Now, if there is GB syndrome clinically, but you have much higher elevated proteins and total counts are also getting elevated, then you have to think of other conditions like what? HIV, neurosarcoidosis, leukemias and lymphomas, right? Because all of these can also cause a GB syndrome like paralysis. Okay, be very, very clear. Fine. So that is about your CSF findings. Now let us understand a bit about nerve conduction studies and its findings in GB syndrome. So now let us understand the nerve conduction studies and how is it helping you in the diagnosis of GB syndrome. Right? So nerve conduction studies, what does this mean? So in cases of neuropathies, we do a study that we call as nerve conduction studies, where we basically stimulate a particular nerve using electrodes. Okay, so you stimulate the particular nerve using electrodes and you see the velocity of the conduction and you see certain graphical changes, and whenever there is a damage to the nerve, then you will see what kind of differences are seen in your nerve conduction studies. So this is the simplest way to put it forth. Now let us look at what are the parameters that we see in a normal nerve conduction study. Okay, so whenever you do a nerve conduction study, as this diagram indicates, you, let us say, are testing the median nerve. So for example, you are testing the median nerve. Okay, so to test the integrity of the median nerve, you will have to stimulate the median nerve using an electrode at multiple points throughout the course of the median nerve, right? So that is how you understand the integrity of the median nerve, okay? So now for simplicity purpose, we are having two electrodes. One electrode is present proximally, one electrode is present distally, okay? One electrode is present proximally and one electrode is present distally, okay? Fine. So proximal electrode, the nerve impulse will take longer time to reach the proximal electrode, right? So for example, in this electrode number 2, which is present more proximal in the body, you can see that the time taken for the impulse is taking longer time and it is smaller in its amplitude as compared to the impulse which is basically picked up by electrode number 1, which has a shorter time and it is higher in its amplitude, okay? So these kind of changes is what we see when we do a nerve conduction study. Now let us understand the terms. So whenever you get a potential like this, whenever you get a tracing like this, the time taken for the potential to develop is called as latency. This is what we call as latency. Then the height of the curve is called as amplitude, and the total time to which this potential is there is called as duration. So time taken for the beginning of the activity is latency, total time is duration, and the height of the curve is amplitude, okay? Then you get two types of action potentials. The two types of action potential include a SNAP and a CMAP, okay? SNAP stands for sensory nerve action potential. SNAP stands for sensory nerve action potential. CMAP stands for compound motor action potential. Okay? So basically you get impulses from both the motor component of the nerve as well as the sensory component of the nerve, right? So you get the action potentials called as SNAP and CMAP. SNAP is your sensory nerve action potential, CMAP is your compound motor action potential. Then you should understand what is this temporal dispersion. What is this temporal dispersion? So like I told you, when you are stimulating a nerve proximally as well as distally, a normal phenomenon is that the proximal electrode will have a longer latency. It has a longer latency and a smaller amplitude. This is normal, okay? But if there is a more than 20% change in the CMAP amplitude or more than 50% change in the duration, right? So if there is a more than a 20% change in the amplitude as compared to the distal one, and there is a more than 15% change in the duration of this your second action potential, then this is what we call as temporal dispersion, and this indicates that the temporal dispersion is prolonged, and temporal dispersion is usually prolonged in your demyelinating neuropathies, okay, right? So when we compare the proximally stimulated action potential versus your distally stimulated action potential, the change in the amplitude should not be more than 20% and the change in the duration should not be more than 15%. If this change is higher, that means that the temporal dispersion is prolonged and it is a feature of demyelinating neuropathy. Alright, clear? So this is about, in very basic terms, about what is your nerve conduction studies and the various terms, so that you understand, you don't have to memorize the differences in your GB syndrome. Now whenever we do a new nerve conduction study, a neuropathy which is basically a problem with the nerves, can be classified as demyelinating and axonal. So a neuropathy can be classified as demyelinating and axonal neuropathy, okay? So what is the basic difference? The basic difference is in the pathophysiological changes that happen in a demyelination versus an axonal neuropathy. Demyelinating neuropathy means that there is damage to the myelin sheath, like in your GB syndrome. Axonal neuropathy means that there is damage directly to the axons. So their nerve conduction patterns are slightly different, and let us see what is the difference. Okay, so first point is that myelin sheath in the peripheral nervous system basically helps in increasing the velocity of the conduction of the impulses, and it undergoes saltatory conduction where it jumps from one node of Ranvier to the other. This we already know, right? So this is a velocity dependent pattern. And when there is demyelination, as you can see here, on your nerve conduction studies, the velocity of the impulse or conduction will be reduced. But your axonal neuropathies depends upon the number of axons, and hence it affects the amplitude but not the velocity. So please understand the very basic difference between your demyelinating versus axonal neuropathies on NCS. The velocity is reduced in demyelinating, but amplitude is reduced in your nerve conduction studies and axonal neuropathies. Then distal latency is prolonged in your demyelinating neuropathies. Okay, because the velocity itself is prolonged, that means the time taken for the action potential to peak is also going to be prolonged. So the distal latency is prolonged in your demyelinating neuropathies. Okay, then there is increased temporal dispersion. The temporal dispersion we have just discussed, it is more in demyelinating, but it is not there. There is no change in the temporal dispersion in axonal neuropathies. Another characteristic feature that you will see in demyelinating neuropathies on your nerve conduction studies is the presence of conduction blocks. Okay, it is not there in your axonal neuropathies. Then we see something called as F-wave reflex. F-wave is basically a test which is used to see the intactness of radicals, right? So here you have a retrograde stimulation. You have a retrograde stimulation of the radicals. So actually the impulses are carried from the muscle to the spinal cord and back to the muscle, and this entire cycle is called as your F-wave reflex. And the F-wave reflex is affected. The F-wave reflex is affected or decreased in your demyelination, whereas this is not affected in your axonal neuropathy. Okay, so we have understood what is the difference between your demyelinating versus your axonal neuropathy, and understand that this entire demyelination and all the findings that we have seen here is basically your NCS findings of GBS as well, because the basic pathophysiological process in GBS is also demyelination. So remember, demyelination, the velocity is going to be prolonged, the distal latencies are going to be prolonged, then the amplitude is going to be the same. Here in axonal the amplitude will be reduced, but amplitude will be normal. Remember, amplitude will be normal, velocity will be prolonged, and you have temporal dispersion, you have conduction blocks, you have loss of F-wave reflex. So this is very clear what are the nerve conduction study findings in GBS. Now, the diagnosis is brought about by a criteria that we call as Brighton criteria. Okay, so the Brighton criteria has put forth certain diagnostic criteria for AIDP as well as Miller-Fisher syndrome, and it involves both clinical as well as laboratory criteria. So what are the criteria? So based upon how much of these criteria is involved, you classify it into the levels 1, 2, 3 and 4. Similarly for Miller-Fisher syndrome as well. So bilateral flaccid paralysis of limbs, absent deep tendon reflexes, monophasic illness, very important. GBS is a monophasic illness, right? So once the process starts, it usually reaches its peak. It reaches its nadir within 28 days, within 4 weeks, right? So it starts in less than 12 hours because it is acute onset, and it reaches its peak within 4 weeks, and it does not progress beyond that. So that is a very important feature, and that is actually the part of a diagnostic criteria of GBS. Then presence of albuminocytological dissociations, EPS studies, which is your nerve conduction studies, is positive and no other cause is found. If all are met, it is a level 1 criteria, right? If few are met, all the clinical are met and laboratory criteria all are not met, then it is level 2, right? Then if the laboratory criteria are negative but the clinical criteria fits GBS, then it is level 3 evidence, most probably a GB syndrome, and you have level 4 when you cannot completely fit it into a GB syndrome diagnosis. For Miller-Fisher syndrome, again you have bilateral ophthalmoparalysis, bilateral DTR is lost, and there is ataxia, which is your triad of your Miller-Fisher syndrome. Absence of limb weakness, yes, that is also an important diagnostic criteria. Again, monophasic illness, albuminocytological dissociation, nerve conduction study here will be normal because Miller-Fisher variant does not cause any weakness. It does not cause neuropathy. Okay. So if all the criteria are met, level 4. If lab criteria is plus minus, level 3. If lab criteria are negative and all the clinical criteria are met, then it is level 3. Okay. And if all are not fitting in, then you may have a diagnosis of Miller-Fisher, but it is not confirmed. So this is your Brighton criteria for diagnosis of GB syndrome and Miller-Fisher syndrome. So what are the differential diagnoses for GB syndrome, predominantly AIDP, right? So basically we are looking at what are the differential diagnoses for a quadriparesis, with cranial nerve involvement. So very important, we have diphtheria, Lyme's disease, polio. Polio can also cause flaccid paralysis, especially acute polio because of involvement of anterior horn cell, right? How does diphtheria present? Diphtheria, on the other hand, presents as descending paralysis, right? It presents as descending paralysis, not ascending paralysis, but it can be confused with GB syndrome because it can cause cranial nerve involvement and flaccid paralysis. Lyme's disease causes bilateral facial nerve involvement similar to GB syndrome, and it can cause ascending paralysis as well. So that is a very important differential diagnosis. Then CMV polyradiculitis. CMV polyradiculitis is especially common in HIV affected individuals, and it causes proximal weakness because it involves predominantly the radicals. Then OP poisoning can present with flaccid. It can present with flaccid quadriparesis, similarly with your shellfish poisoning. Okay. Then hypophosphatemia is an important metabolic cause which can cause quadriparesis, predominantly of the element type. This is because it causes myopathy. Myasthenia gravis is also another important differential. But myasthenia gravis, how will you differentiate? Predominantly because of its fluctuation. Fluctuating weakness is a characteristic feature of myasthenia to help it differentiate from GB syndrome. Then you can have botulism. As well, which again causes descending paralysis and cranial nerve involvement. Okay, so this is about the various differential diagnoses of AIDP. Now, when you come to the treatment of GB syndrome, there are certain very important points that you have to remember. In a patient with AIDP, there are certain important things that you have to watch out for. One is involvement of the respiratory muscles, involvement of the respiratory or diaphragmatic muscles. Involvement of the respiratory or diaphragmatic muscles, which can result in a catastrophic type 2 respiratory failure, which is very dangerous, and they may have to be mechanically ventilated, right? That is the reason why you always do a single breath count. For the monitoring of a GB patient. So daily, if a GB patient is admitted under you, go and do a single breath count. In a single breath, you ask them to count from 1 and go beyond 20. If it's going beyond 20, normal, less than 10, abnormal. That means there is an impending chance of diaphragmatic or respiratory weakness. 2. They can have bulbar weakness. And a high chance of aspiration, right? So you have to put them on a Ryle's tube. 3. You can have neck weakness, right? So every time a GB patient admitted, apart from your single breath count, you also have to see your neck holding time, right? So if there is evidence of neck weakness, if there is a low single breath count, all of this means that the GB syndrome is progressing rapidly and they may require a mechanical ventilator. 4th, always look for autonomic dysfunction. Right? Check your BP, check your heart rate, because you can have fatal arrhythmias. So always look out for these. So this is about how do you monitor a patient with GB syndrome. What is the treatment for GB syndrome? Always remember that there is no role of steroids. In GB syndrome. There is no role of steroids, and the treatment is with Plex or IVIG. Treatment is with Plasmapheresis or IVIG because the already formed antibodies have to be removed. Okay, so urgent treatment is with IVIG or Plasmapheresis. Okay, so this is about your GB syndrome. Now let us move on to the next type of neuropathy, which is your CIDP, which stands for chronic inflammatory demyelinating polyneuropathy. Okay, so AIDP is acute inflammatory demyelinating polyneuropathy. CIDP is chronic inflammatory demyelinating polyneuropathy. So how is a CIDP different from an AIDP? CIDP is also an acquired autoimmune demyelination which predominantly affects your peripheral nervous system, right? But the onset is more insidious in onset as compared to GB syndrome. It's more insidious. A GB syndrome patient will tell, I had weakness from such and such a day. But CIDP patient may not notice his weakness because it is slightly more slowly progressive and hence its onset is more insidious. The progression of the symptoms can last for more than 8 weeks. That's why it is called chronic inflammatory demyelinating polyradiculoneuropathy, right? Because in GB syndrome, like we had mentioned in the Brighton's criteria, AIDP has a peak of 4 weeks, and once 4 weeks has reached, AIDP generally does not progress any further. It generally does not progress any further. Okay, so AIDP generally does not progress any further, reaches its peak within 3 to 4 weeks, whereas CIDP symptoms can be continuing to progress. So what are the symptoms? Symptom wise, how is CIDP different from AIDP? So symptom wise, CIDP has more sensory symptoms. It has more sensory symptoms. Okay, it has more sensory symptoms and it has more distal involvement. It has predominant distal involvement, more sensory symptoms, sensory loss can be there, weakness can be there. Okay, so it's not a fulminant flaccid paralysis that you are going to give, right? So here you will have a slightly slower progression of disease with more sensory symptoms, more distal symptoms, and there is no autonomic involvement as you see in AIDP. They do not have any autonomic involvement, right? So they do not require a mechanical ventilator. They do not have this kind of a progression. Okay, so what are the etiologies? It can include myeloma, HIV, SLE, Hodgkin's lymphoma, right? So these are the various etiologies for CIDP. So autonomic nervous system involvement is not there and the mortality is much lesser so because it is slightly chronic in nature, right? And a characteristic feature that we find on examination is the presence of this nerve thickening. You can find thickened nerves. What are the other conditions where you can find nerve thickening? So whenever you examine a patient with peripheral neuropathy, you will have to look for thickened nerve. For example, your ulnar nerve, your sural nerve, all of these can appear thickened. So the other conditions that you have to know are leprosy. Leprosy can cause thickening of the nerve. Refsum's disease. Okay, leprosy, Refsum's disease. Then amyloidosis. So these are some of the other conditions where you can have thickening of the nerves. When you do a nerve biopsy, so many a times when you have thickened nerves, you go ahead and do a nerve biopsy. On histopathological examination, you find something called as onion skin appearance in CIDP. You have onion skin appearance in CIDP. And why do you find this? It is mainly because of attempts of demyelination followed by remyelination, demyelination followed by remyelination, which results in this onion skin appearance, right? So here the treatment, how is it different? Here steroids have a role. Apart from this, plasmapheresis and IVIG can also be administered. Okay, so this is about CID. So with this, we've come to the end of our chapter on demyelinating neuropathies, your GB syndrome and CIDP. Thank you.